Hello, everyone, and welcome to today's webinar. It's all about revenue, MACRA final rule. My name is Alex Schooling. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You will have the opportunity to submit questions during today's presentation by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. Before I introduce today's speaker, I would like to note that today's webinar is the first webinar of iHealth Innovation's MACRA Final Rule series. Please keep an eye out for our upcoming Final Rule webinars that are specialty focused for orthopedics, radiology, primary care, and cardiology. I would now like to introduce Justin Barnes. Justin is a corporate, board, and public policy advisor. In addition, he's the chairman emeritus of the HIMSS EHR Association, co-chairman of the Accountable Care Community of Practice, and partner at iHealth, where he assists organizations with industry strategy and leadership. Justin is also the host of the weekly syndicated radio show, This Just In, on Healthcare Radio and Business Radio X. Justin has formally addressed or testified before Congress as well as the last two presidential administrations on more than 20 occasions. He's appeared in more than 1,200 journals, magazines, and broadcast outlets. With that, let me turn today's presentation over to you, Justin.
Thank you very much, Alex, and thank you very much to everybody who's taken the time to join us today. If you've ever heard me before speak, I do cover a lot of ground. I'm originally from Boston, so I tend to talk fast. I will try to slow down my cadence just a little bit, but we will cover a lot of detail, again, a lot of content over the next hour, and certainly want to leave time for everybody to ask questions, and we'll get to everybody as much as we can. We do have a couple hundred people on the line, but I just welcome, and it's a pleasure to be here and certainly have the opportunity to speak with you. The MACRA final rule, as everybody knows, came out about probably 2.5, 3 weeks ago now, 2,400 pages. But the good thing about it is it wasn't as daunting as we traditionally see. Alex and I and other members of the team have been doing this for about 11 years now, and we spend, probably hundreds and thousands of hours pouring through legislation, regulation, working with Capitol Hill. But when we get these rules, they tend to be sometimes 800 to 1,000 to 2,000, 3,000 pages, but it's all rule. What this is, a lot of the bill in this regulation was around transparency and public comments. And I think that was a big step. And you're going to hear this theme from me throughout today and throughout my additional speaking engagements. As Alex mentioned, we'll have a lot of shorter ones coming up over the next 6 weeks, especially specific. So you'll have cardiology, radiology, orthopedics, and primary care to include OBGYN and pediatrics. But what CMS did is publish, probably, I don't even know, it's 1,000 pages plus of just public comments to show, and then their answers to other public comments to show how they have lessened the burden, how they've offered a lot more flexibility, how they've given simpler timetables to different quality measures and different metrics. So it's pretty cool, I think, overall. So I have a very positive tone when it comes to MACRA and MIPS and the QPP, the Quality Payment Program overall, because it weaves fully into where the entire healthcare system is evolving. This is much bigger than just Medicare. We have Medicaid programs that are evolving just like this and actually evolving even faster in some communities, and we're actually engaged in a lot of those. And certainly here with Medicare, but also every private payer, every commercial payer is moving in this direction. And if anything, it's one of my business partners here at iHealth came up with the term, it's the underlying multiplier that is not really spoken about. It's that how many of these types of programs are woven into all the commercial payers that we have in our communities that either will affect panels, referral streams, and just participation in different programs and participation in how healthcare is evolving and how to thrive in the future. So there's a lot here that I don't think people are paying full credence to. So nonetheless, I look forward to our discussion. Again, we'll leave time towards the end. As Alex mentioned, all of these slides will be available to you probably within 24 hours. Feel free to use them, share them with any of your peers. We'll actually have another one covering the full final rule on December 1st at 12 p.m. Eastern. And that, again, will be a full review like we're going to go through today, but also we'll include any additional interpretations or info that we have received from CMS or other partners in the industry. So feel free to join that one again at December 1st. That'll be a full one. And then we also have 8 specialty-specific ones over the next 7 weeks. So as you see on your screen right now, changing healthcare, I think you guys all see how the landscape is evolving. And really, so from my perspective, I'm participating in helping physician practices as well as hospitals expand their services, but also very importantly, their strategies. So when I walk into a community, we're going to, I may go into the large specialty group or a primary care group, or even here I live in Atlanta, a ophthalmologist who's looking to take on some accountable care type models and then also participate in how the future of healthcare is evolving. So I work with all different types of specialties, and so does my company, but we really look at them holistically. And that's where we're going to start off on kind of managing some of the financial components of your practice or your hospital, but then also how it leads into value-based care, because they are fully integrated, fully woven together. And as you're going to see over the next 4 or 5 slides, how the revenue cycle is almost more important than all these quality payment programs that are coming down the pipe. And I'm going to get to that. But looking at expanding services, programs, participating in different programs, regionally as well as nationally, what other partnerships can you derive or can you create to expand your strategies for your practice or your hospital? And then also make sure you're navigating consumerism and consumer access to care. And hopefully everybody's looking at risk-based contracts. And as I opened with how, obviously this is a form of risk-based contract for sure under what NIPS and the QPP has put out and CMS has put out, but everybody is putting out these risk-based contracts. So you just want to make sure some are larger than others, but you want to make sure that you're exploring those and you have a partner or maybe you have staff on site that knows how to manage those and engage those. But they're certainly changing, how healthcare is delivered in our landscape. And then also something that's near and dear to my heart is physician practice strategies to stay independent. We've seen a big, broad swath of how practices have either closed their doors or sold off to the local health system or hospital or merged to the hospital or so forth. But I'm also seeing a pendulum effect. And I'm working with a lot of them that maybe sold off or merged, and now they're coming back out on their own. And they want to set their own 5-doctor, 10-doctor, 20-doctor group, sometimes specialty specific and sometimes multi-specialty, or sometimes just primary care. So there's kind of everything, but I want to say on a positive note that physicians aren't leaving the field or going to work all for hospitals. That is not the case. I know it seems like there's a lot going on and a lot of practices have changed, but a lot of that gets a little overblown. But I think I want to make sure that everybody knows the positive message around you can equally stay independent. You certainly have to evolve with how healthcare is evolving. You have to look for additional services to provide, and I'm going to talk about that. Leverage some innovations that you probably already have or you can add on that are little or no cost. But then also just overall business practices to evolve, because there's a very great opportunity for everybody in healthcare. So it's not all gloom and doom like we tend to read. It's like the negative always seems to sell, but the truth is there's more money being poured into healthcare than ever before, and there's more money to be had by everybody. And I promise that because I live and breathe that every single day. So at a high level, and I'm going to start to dive in deeper and deeper, but this is how you evolve and how you really want to set yourself up to thrive, is we got to focus on optimization. You got to look at efficiencies and economies of scale. So when we say that, look across your organization and look for new revenue sources or opportunities to increase your profitability in your current services. And I'm going to dive deeply into the revenue cycle, because that's where, when you look at the future, even starting in 2017, are immediate opportunities for additional revenue. 90% of those are going to come from optimizing your revenue cycle, and maybe 10% or so will come from a pay-for-performance or a PQRS or meaningful use or some other type program. But then also in 2017, you want to lay the foundation for where you're going to go with MIPS and the QPP, the Quality Improvement Program. But like I said here, the number one area is optimizing your revenue cycle. It can bring, I promise you, so again, what I do every day, it can bring an extra 5, 10, 15% to your bottom line. And this is just across the board. So, and no matter where you live, no matter what specialty you're in, we find so much room and so much opportunity there for efficiency. So I'm going to dive into that because that is going to pave the way for you to have the resources that you need to be able to manage these evolutions in healthcare, these new care coordination models, these outcomes-based models, the expertise that you need to have on site, the additional resources that you may want to bring on or reallocate. It's not about adding more resources. It's about the right resource allocation. And again, I'll touch on all that. But also, it's very important to optimize and create more efficiency. So look at your organization and how you conduct business and also how is it to conduct business with you. So you want to make sure that you align your processes, the services that you provide, and innovations that you use internally and externally. So innovations that you use, such as health IT or practice management or electronic health records or any type of a portal, then also that's the internal technology, but also externally. What technology do you use to manage and educate your patients or engage your patients? Share care plans with them. Make sure that they have all updated information. Patients are very smart. I don't think that we use them enough. They're usually free labor because they do all the work on their side, but they really do. They know their meds traditionally. I mean, obviously there's some that don't or can't, but again, I've been doing this for almost 20 years now, and when I engage and I look at these portals and I look at the information that patients are putting in, and you actually inform them and educate them, it's pretty strong. So we want to make sure that we're using those types of strategies, patient engagement, but also scheduling. And these next three pieces are actually just fundamental business components. So no matter what business you're in, doesn't matter if you're in healthcare or you're in technology, you're in finance, you're in automotive, transportation, make coming to see you or doing business with you as easy as possible. And there's so many really cool scheduling applications that are out there that some cost money, but some don't. These are just processes, but make it easy to get a hold of somebody to schedule an appointment, or better yet, schedule online where you don't need to have somebody in the middle of it. But make it easy to do business with you. Make it easy to schedule appointments, throughput within your organization. Appointments, generally, make sure that the appointment process is simple. You're not making people wait 35, 45, 55 minutes. Patient satisfaction is going to be 5 to 15% of your current reimbursement rates moving forward, and certainly bonuses moving forward. So there's going to be a lot of money in patient satisfaction. People sit in your waiting room for an hour, that's a tough thing. And also, it probably is going to highlight a lot of inefficiencies that could be in the practice. And again, this is where you're losing money left and right. So you want to make sure the appointment process is seamless for patients to the best of your ability. I mean, they may have to wait a half an hour once in a while, but in and out. And my doctor, I'm in and out of there. Only I'm in there to see the doctor within 5 to 10 minutes of me walking through the door. That's fair. Even 15 minutes is very fair. But sometimes people are waiting an hour and 15 minutes, and that's tough. That's going to be a very difficult process to manage moving forward. And then certainly making payments. There's a lot of great programs out there. There's companies like Patient Co. and there's other ones out there that make it easy to make payments for your patients. And that's critically important. Make it easy for people to give money to you. So it's something that's kind of near and dear to my heart is I always want to make it easy to work with my company, make it easy to visit us, and make it easy to pay your bills. And so those are kind of strategies. They're kind of simple. And they're kind of no-brainers in some ways, but you'd be surprised when you work with practices what comes up there. So now looking over to your revenue cycle, I'm going to spend a little bit of time on this before we dive into MIPS and APMs, but these are very woven together. So you want to optimize your revenue cycle today, really as soon as possible. So the very first bullet here is audit provider workflow. And when I say what I mean by this, and for example, is make sure that the providers are capturing and noting all of the elements of the patient encounter. You also want to make sure that providers are capturing the right information in the right field. Because in electronic health records specifically, when you use an EHR and it's set up, you might capture information in several areas, or you may document in several areas. Well, there's ways that we can update, or experts can update, and you even yourself, if you have an expert on site, to update that EHR template to reduce clicks. That is one of the biggest downfalls of EHRs, and the biggest complaints are, well, too many clicks. Well, this HR optimization is very key to every single practice. And also, it's a very key strategy to deploy every year, and maybe every 6 months, is to look at how you template and you manage the EHR, electronic health record. And certainly how you set up clinical and financial alerts and reminders. So the things that we're looking for that you want to capture. You don't want alert fatigue, but you also want to make sure that you are capturing information where you need to, and people are reminded to put information in. So there's a lot of opportunity, just an audit provider workflow. That kind of feeds very well into comprehensive documentation and notation. It is rampant that we have undercoding, under-documenting. You want to make sure that people get paid for what they did. Your doctors are working hard, you're working hard, but people try to downcode or undercode, and I call it under-documenting. You want to make sure you get paid for what you did. And specifically on assessments, questionnaires, evaluations, services, tests, and screening. You want to make sure you're capturing that information, because all of those components count towards your MIPS score. And you want to start making those count towards your MIPS scoring. And I'll dive in deeply into MIPS in a little bit, but I kind of want to point this out, because again, this is all the steps on the revenue cycle side to make your clinical side much more relevant and easier to report on. And also, a great best practice is random chart audits, 10 per provider. You can do these monthly or bi-monthly. And this needs to be done by a coding expert, but I promise you, that's where we find traditionally 3 to 5% of additional revenue just in doing chart audits and making sure that we're using the right codes. And now with ICD-10, it's even more important at the right time. And here it is. So regular review of coding by expert billers. You want to look for missing charges. So you can put on consultation, there's no notes, wrong provider noted, there's downcoding, there's upcoding, the wrong ICD-10 codes. That's very relevant now, certainly after October 1st, looking for missing modifiers. All of that work by an expert biller will prevent rejections, denials, and even audits. So again, very important. And like I mentioned earlier on, even keep the future in mind, because we want to optimize coding and our EHR for whatever program that you're going to navigate into, whether it's PQRS, whether it's MIPS, whether it's an alternative payment model, or any other quality reporting initiatives. So again, we're spending a lot of time on just what CMS is doing today, but every single payer, every commercial payer out there is also putting these programs out. And then one thing I want to say here is, just because you aren't participating in one or you haven't heard of one in your region by your commercial payer, doesn't mean it doesn't exist. You want to ask your plans, certainly now when we're going through our contracts for 2017, you want to go there and ask, what is available to you? Not what you qualify for today, based on your specialty or your strategy, but what is out there? Because you might have a 5-doctor ENT group or a 5 or 8-doctor primary care group, but you might be competing with one across town or even in the next building over that has an alternative payment or a quality reporting initiative with one of these payers that you don't have access to. And I'm going to tell you strategically, they're probably going to do a little bit better than you. And to attract patients, show improved outcomes, increase their bottom line in the revenue cycle. So it's very important to understand what's out in your community and inquire, be proactive about it, not wait for them to come to you. Managing credentialing, monitoring PAR and non-PAR providers. This is an area I say leverage a partner here, because I know there's credentialing team members, but when we go in there and help a practice, you have to play the game with the payers. There's one payer that we have up in New York that we ended up getting an extra $15 million. It is a large health system, it's a large hospital, but we've got them an extra $15 million a year by playing the game. The insurer was pulling the physicians off their roles every single month. So we had to re-credential our doctors, every single doctor, every single month. But when we found out the game that they were playing, we came out $15 million ahead. That happens all across. Now, that's a large example because it's a large health system, but that still could be hundreds of thousands of dollars for your average practice. So, again, there's a lot of opportunity there, and credentialing is a big component of that as well. And optimize, collections with eligibility verifications, prior authorizations. Those are just ways to streamline that. And, again, this is a good 1-2% increase, or at least 1%, if not 2%, increase on the bottom line by deploying that strategy. And then also managing fee schedules. You want to do an analysis and run financial analytics every 6 to 12 months to make sure that you are getting paid per your contract. 80% of practices don't do that. And that's a critical component. It's worth every nickel to deploy that. Because, again, you got to play the game. These payers, they make money by not paying. They make money by denials, by denying claims. They make money. They float all that. You guys know that this is billions of dollars a year that they float, and the interest on that is significant. That's part of their business model. So you want to play their game. Now moving over real quickly to efficiencies and economies of scale. And this is where, because you do want to make sure it's not just about revenue cycle, you can probably 5 to 15% additional money there, but you've got to balance that with how the future of healthcare is evolving. So you want to understand and manage your cost structure. Transparency is important here because you got to understand, and this is where a strong partner will help you understand what your costs are, and getting down to cost per claim. But you got to understand what went into that visit, how much did that visit really cost you, because eventually you're going to go to a negotiation with a payer, and if a encounter costs you $160, but they're going to risk at $150, you need to know that. You can't take that at-risk contract if it costs you today $160, but you can take it if you say, you know what, we're going to look at this differently. We're going to optimize our operation. We're going to get our cost down to 120. So we could take it at 150 and make $30 profit on each visit, each encounter. So that kind of stuff. So that's what you really got to look at, and that's how healthcare is shifting. And when we say efficiencies and throughput. And so again, streamlining operations, increase your throughput. You want to look at cost of operations. It's increased 50% over the past 10 years. But I promise you, your payments, your money that you've made has not increased 50% over the last 10 years. You have not made 50% more annually. So your costs have gone way up, but the money that you've made, your revenue has not kept pace even remotely. And that's why, getting revenue cycle strategies deployed are critically important and a lifeline of many practices. When we step in and we help practices, we keep them solvent. We bring them out of the brink of going under. So and it's only going to get worse. And because with ICD-10, it changed a lot, and just the complexity. And then the payers are lumping on and getting more complex to handle and manage. So you've got to mitigate your cost of operations. You got to look at your staffing model, and you've really got to assess productivity levels to accommodate new wellness, care coordination, and pop health activities. And when you do deploy new strategies and some co-sourcing or whatever you can to create efficiency, it isn't about letting people go or firing people. You're running a mini business. If you're inefficient people or people who just aren't up to par and fail, you do have to get rid of them. But a lot of the times you can reallocate people to revenue-producing positions or budget or revenue-neutral positions that will help you grow your practice, and then therefore they turn into revenue-producing opportunities long-term. All of us that run companies go through that. So you just want to make sure that you're doing that at the practice level. And you can do it. A partner can help you do that, but there's lots of opportunities there. And you want to look at wherever you can automate and certainly co-source. And that's something that I've mentioned. You get a partner to help you with some of these strategies that has the experience. That's what they do every day. And usually, companies like ours, we go at risk. We don't make money until you make money. That's very important to find partners who will go like that with you. And so to highlight this, you've got to reduce the cost per case because that'll increase your overall efficiency and your revenue. You've got to leverage innovation internally and externally. So again, use, throwing software and technology at the problem is not what we advise. I mean, sometimes you may need additional technology. You certainly want to keep all of your EHRs and your health IT updated on the current versions and push your vendors to give you the very best versions. And a lot of those are free. They're part of your maintenance package that you pay every year. So you want to make sure you stay to do that. But a lot of the stuff coming out is just about getting some of the expertise and not buying all this new stuff. So I promise you that. And implement clinical, financial, and administrative best practices. Looking at your organization and your operation a little bit differently so you can really scale with how the industry is scaling. So talking real quickly on some key performance indicators to manage your practice. So you want to set up KPIs by your specialty and really look at your workflow, look at industry best practices, and MGMA is a great source for best practices for any specialties, but also for revenue, cost per case, cost per claim, all those types of scenarios. But here's some right here. So in revenue optimization, this increases dollars as well as your cash flow. So you want to look at denial, root causes, and appeal success rate. We appeal 100% of claims as part of our best practice. You have to. Or we appeal 100% of our denials. The industry standard is 60%, or less in some cases. So there's a lot of money in it. If 10 to 20% of claims are denied just across America, on just as a national average, that's a lot of money that practices aren't going back after. If you're only going after 60%, you need to go to 100%. You're just leaving so much money. You've got to be tenacious in that. So you're leaving a lot of money on the table. That's one of the first areas. And that's actually one of the biggest areas. That's number one there. Underpayment reviews. You want to do that, again, the payer analysis every 6 months, maybe every 12 months. But I promise you the payers play this game, and you've got to play the game with them. And also look for incomplete and missing charges. Again, this is all revenue to the bottom line. This is where we'll come up with 3 to 4% additional cash flow and revenue in this type by optimizing the revenue. Efficiencies and throughput, I mentioned this a little bit before. Patient wait times, you want to begin to scale those down. You want to look at efficiency so you can get the throughput of the patient, and then maybe also pull in more patients. That's, marketing in your practice and even showcasing your KPIs so people know how efficient it is and their outcomes will improve by working with you. And you see a lot of billboards when you drive through communities and you drive across states now. It's primarily hospitals, but now the practices are getting into this game and marketing themselves and pulling in the right patients. I think that's very key. And again, that's running any business. Again, all we're doing is deploying best practices for all businesses in America into healthcare, with practices, with hospitals. You want to help with cancellation and no-shows, and real inexpensive technologies can assist you there. But you want to, deploy technology wherever you can. This isn't a manual process. I'm not saying you take on labor. I mean, there's so many innovative technologies that are pennies on the dollar that you can deploy and just get 10, 15, 20 times the ROI. And looking at coding turnaround time. This is another thing. I mean, it really should be 24 to 48 hours. And if it's much more than that, you're losing money and leaving a lot of money on the table. And then understanding your operational costs, and again, cost per case. You want to look at the true cost per claim, because once you can get down to this number, you can negotiate with the payers much better. And that's going to be the big key here, is you negotiating for higher rates, into better contracts. And you can do this yourself. You can do this with partnerships. You can do this with other organizations joining you. So there's so many different strategies to deploy, and this is where the transparency. When I mentioned you want to have more transparency in your practice, it exactly comes down to this. And again, every year, comprehensive internal audit of the practice's costs. You want to understand where your costs are and how every year you're reducing them by, say, 2%, 3%, 5%, and have a KPI around that. These are just best practices that we deploy with our practices and that we've seen in the industry. So now diving into MACRA, MIPS, and the alternative payment models. I think everybody knows that this bill was passed back in 2015. I personally had testified on it, I think, 4 times to try to create, have a very large stakeholder group, but create a program that reduces or gets rid of the flawed formula on the SGR, the sustainable growth rate, and create a program that physicians know where their payments are going to come from. Everybody knows where the creation of where this program came from. It came from because we had this flawed formula that every single year we're always facing. When I first started working on it, the 10% annual cut. Every December with the doc fix or doc cut was 10%, then with a 15, then or 14, then the 15, then the 17, and then that 21% was a cut that we had to go find all these patches for every single year. So we said, enough of this, finding these patches every year with a doc fix. Let's go create a solution instead of just Band-Aids every year. And so this is where MACRA came from. So it was passed in 2015. We saw the final rule just back in October, just 3 weeks ago, and now we are in a 60-day comment period. But nonetheless, we know about 98% of the final rule and how it's going to come in. So now I'm going to walk through the options. The bottom line with MIPS and MACRA and the QPP, the Quality Payment Program and the Alternative Payment Models, they're very flexible. Everybody that can hear my voice right now and that listens to this talk at later dates will be in very good hands. And we're even going back and helping people in a lot of scenarios where even our previous organizations and previous companies be successful, because it is not hard to certainly avoid a negative payment adjustment. And it's even, one step up from there, you can even make money and then make a lot more money in some scenarios. So it is not difficult, a lot of flexibility, and I'm going to walk through those options right now. So for an eligible physician or clinician, or the definition is eligible clinician, part of the rule, you're given 4 options to comply with the new payment schemes. And again, we need to start those in 2017. And the payment changes and adjustments will all occur in 2019, but you've got to start in 2017. So option 1, which is it's called a test option. It allows provider to report 1 quality measure or 1 improvement activity, or 1 or up to 5 advancing care information activities to avoid a negative payment adjustment. You have to collect those over 90 days. They'll give you 1 quality measure, 1 improvement activity, or 5 advancing care information over 90 days to avoid a negative payment adjustment. So it's very simple. There's 1, 1, or 5. So again, and this is called a test option. I want people to understand how easy it is to avoid a negative payment adjustment. And again, as you can see in my next slide, that I'll talk about right now, is everybody starting in 2016 received a 0.5% increase. And you'll get another 0.5% increase in 2017. So we actually are getting, there is additional money here for everybody. But if you're eligible in this program, avoiding the negative payment adjustment, the 4% negative payment adjustment, is very simple. Now, option 2, called the partial option, allows providers to submit measures and activity data for 90 days. This means their first performance year could begin after January 1st, 2017, to earn a neutral or even a positive payment adjustment. So the first option is just to avoid a negative payment adjustment. But option 2, this is where most people are going to fall into this one, I believe, in 2017, is you can submit a mixture of measures and activities data for 90 days or more, and they can start at some point. So you can either do it for 90 days or 180 days or 270 days or whatever it is, and then have a mixture of measures and activities, and they would get 1% or 2%, or maybe even 3% of an incentive. It really all depends on your mixture and what you do for measures and activities. And I'll dive into some of that in a moment. I really want to emphasize here the flexibility. There's option 3, which is called a full option. And this is really practices that are ready to go on January 1st, 2017, and offer the full 365 quality reporting. And then also they should be able to earn a moderate positive payment adjustment, should be 3 to 4%, really depending upon, again, mix of measures and the bonus objectives they go for. So that's really the 3 main options. There is a 4th option, which is the advanced alternative payment model, such as the Medicare Shared Savings Track, which is ACO, which is Track 2, the Oncology Care Model, which will start in 2018, the Next Gen ACO model, or even CPC Plus. But most people, I think 60 to 70% of the people, 80% of the people, or providers, clinicians, are going to be going for options 1, 2, and 3. But very important, this is not difficult. To report 1 quality measure over an 90-day period is very simple. 1 improvement activity or advanced care information activity. These are very simple things to do. Well, 5 ACI measures you need to do, but very simple to do over a 90-day period. So here's kind of the stepping stone. And again, these are all cumulative. It's very important to understand. So if you go for the MIPS track, as I just reviewed 3 of the components of the MIPS track, year 1, you'll get a plus or minus financial and payment adjustment. Year 2, again, this is cumulative, we'll get 5% in year 2, 7% in year 3, and 9% in year 4. So it's a pretty significant amount of money. I'm going to go through some of those calculations in a couple slides from now. But it's pretty significant. So you do want to pay attention to it. You do want to, certainly if you're eligible, you want to go into the program because, again, a lot of money. And as I mentioned before, the clinicians, everybody's getting a 0.5% increase cumulatively over 2016 to 2019. I'm not going to spend much time on the advanced APM or not advanced because the majority of people are really going for the MIPS program that are at least on this line right now. So talking about the performance categories under MIPS. So there are 3 weighted categories for 2017, and the resource use cost category will kick in 2018. So starting in 2017, starting January 1st, You'll have the quality measures, which accounts for 60% of your total score. I'm going to be going through some of those measures here in a moment, but this really replaces PQRS. So if you've already been participating successfully in PQRS, you're very well aligned. There's a lot of measures that are fully integrated into this program under the quality measure that comes from PQRS. So I think that's a big plus. Advancing care information, that measure that replaces Medicare meaningful use, and that accounts for 25% of the total score, again, in 2017. And improvement activities accounts for 15% of your total score. So those three right there are 100% of your score for 2017. And again, resource use costs will start in 2018, and that replaces the value-based modifier. Very importantly here is CMS combined, and this is the first time in my history of working with CMS, that they've combined programs. They usually have all these different initiatives, and they usually get kind of banged up or dinged because people feel like, I'm doing all this reporting. Why can't I just have one program? Well, that's exactly what this MIPS and the quality payment program is all about. It's about having one program. So they've eliminated PQRS, they've eliminated meaningful use, they've eliminated the value-based modifier into starting in 2018, all into one program. So it's I think it's very important to understand how they brought all these organizations together or programs together and in ways to be successful. So you've already gone down the PQRS path, you're very well aligned. If you've gone down the meaningful use path, you're very well aligned to achieve. And same thing with PCMH. You'd be very well aligned with the advancing care information just because that's exactly what PCMH is all about. So let's dive in here for a moment. On the quality side, so for you to be successful, and again, back to the simplicity and the flexibility here, on the quality, 60% of your score, as I just mentioned in the previous slide, you only have to do 6 quality measures to be successful. You'll have over, there's 200 plus to choose from, and 80% of those are specialty specific. So they're going to be very relevant to your specialty, no matter what your specialty is. So there's a lot of flexibility. You only need to do 6. So hundreds to look through. And that's also some of the best practices when you're looking for a partner maybe to help you with some of this stuff is, we have a blueprint that we'll walk in, no matter if you're in cardiology, orthopedics, primary care, radiology, ophthalmology, whatever it is, we'll actually offer you, looking at your workflow, the 6 that we recommend. Or give you 12 and let you pick 6 that you want to go for. So again, it is about picking the right partner here, but it's this is not difficult. It's kind of the bottom line. A lot of flexibility. Now, advancing care information, and this is based on your EHR. So if you have a EHR that's been updated with all the MIPS reporting, then you would go for option 4. And if you don't, then you have you'd go for option 1. But bottom line is, option 1 under advancing care information, you have to report 5 required measures. You have 15 to choose from, but you only have to 5 would be required. Under the ACI transition objectives, 11 measures, and again, 4 would be required. So going back to, it all depends on if your EHR has been updated or not with the MIPS reporting. And then improvement activities, up to 4 activities, you have 93 to sort through and choose from. So again, it shows the flexibility here. 93, you only need to pick 4 of them. And if you're participate in a health professional shortage area, you only need to do less than, up to 2 if you're in a group of less than 15 participants. So, or if you're in groups of less than 15 participants, or health professional shortage area, only 2 activities. So it just shows again that if you're in a smaller group or you're in a health professional shortage area, rural health, it's actually easier and it offers the flexibility. So, all right. So just some quick takeaways. You can pick your pace, as I've covered a lot here. Highly flexible. You choose what objectives and measures fit your practice, your specialty, and your workflow. We've never really seen that as part of CMS programs before. Also, what we've never seen is, if not all or nothing. You can get partial credit and bonuses to avoid penalties and also increase your payments. So pick your pace. Again, you can go for 90 days, you can go for 180 days, you can go for 270 days. But also, it'll be all based on your specialty, your workflow, and again, you can do partial things to get the different credits. You can go for bonuses. So again, a lot of flexibility. Very pleased because that was some of the push and the transparency that CMS published. Doctors, care providers, associations all fought and worked very hard to get that. So I think that's a big win. So now I'm going to walk through some rough numbers. There's not an exact science here on some of these formulas, but these are basically some of the ballpark calculations that can be derived to show how much money. And kind of at the end of this, you can see, you know, when you go for family practice here, a good example. 6-physician family practice, so an average family practice with average size Medicare population, they're looking at about $14,000 in their first year. But then it continues to go up in year 2. So then you're looking at $17,000 in year 2, almost $25,000 in year 3, and then $33,000 or $32,000 in year 4. So that's just a standard outlay for a family practice. Again, that got 6 physicians, and it's about the first year only a couple $1,000s per doc, but it begins to set you up for where you're going. And overall, for whole practice, it is a lot of money. And again, you have to participate. If not, then you have a 4% reduction come. So again, and this is not just about Medicare. Everybody is doing these programs. All the private payers, the commercial payers are also doing these types of programs, or they're going to be rolling them out. And again, you want to make sure that you're part. And if you participate in these, you'll be on different panels. You'll keep your referral sources. You'll be invited into different care models that are evolving in your communities, accountable care models, value-based models, and so forth. So that's why it's very important. And the money does start to pick up over time. And again, this is all cumulative. So here's just another way to represent it on the family practice side. Here's an example. These are not all the measures, but here's an example of the family practice specialty measures. There are 55 to choose from, 43 process measures, 4 patient engagement measures, 4 outcomes, 2 efficiency, and 2 intermediate outcomes measures. Here's just a sample of 4. But we want to show you, and a lot of this people already do on a regular basis already. And it's just about the setting measures, reporting on certain measures, capturing information, and we can set your EHR up, and your partners can set your EHR up to capture all this stuff in your normal workflow because you're probably doing a lot of this work already. Let's just get you paid for it in these new payment models. Here's orthopedics. A little bit more money, more room for some value there. So a standard 6-doc ortho group would get about $35,000 their first year, $43,000 the second year, $60,000 their third year, and $78,000 their fourth year. So it's pretty strong. I mean, there's certainly a lot of opportunities for incentives. But again, you want to make sure if you don't do it, then you get those cuts every single year. And those are pretty significant cuts to walk through. And I'm not going to spend a lot of time on each of these. We are doing specialty-specific webinars. I kind of want to give you just a quick taste of what we'll be covering. And in those webinars, we'll be going into these deep, going through all the measures, going through some best practices, what measures do we recommend, all those kind of points based on each specialty. And we'll be even adding more specialties after the first of the year, but we're doing those 4 that we mentioned at the top of the hour. Orthopedics, here's just an example of there's 21 to choose from, and here's just a sample of 4. Again, it's just a random sample. Now cardiology. So for an average 5-doc cardiology practice, $43,000 the first year, $54,500 the second year, $76,000 the third year, and almost $100,000 the fourth year. So again, it's a good amount of money. And if you don't go for the program, those are the cuts that you get. So again, you don't want to be taking on those cuts. And also, I want to mention there's a program out there called Physician Compare by Medicare, and they're tracking all this. So today, if you go to CMS's Physician Compare page, you will see providers that participate in PQRS, meaningful use. It's a very consumeristic, consumer-facing webpage. Also, all of the care providers that participate and their quality ratings are all going to be posted on there over the next year or so. So, and how they participate in these programs. So you want to be a part of those. It's marketing. It's about, again, like I mentioned, it's being invited to care models. It's being kept on panels. It's being kept in referral streams. You've got to be doing this work to be part of that, where how healthcare is evolving and the new revenue streams in healthcare. So it's not like you can just not do it. So I'm going to walk through this, and again, we're diving into all of this deeply, and I want to make sure we leave plenty of time for Q&A. And here's just a random sample of 4 cardiology-specific measures. And again, we'll be sharing all of these slides with everybody at the end of this presentation. Here's an example for OBGYN. Usually it's a little bit lower on the OBGYN side for the financial incentive. The revenue cycle opportunities are certainly there on the OBGYN side. But for a standard 10-doc OB group, so $12,000 the first year, $15,000 the second year, $21,000 the third year, and about $27,000 the fourth year, because these usually have lower Medicare populations. But as I mentioned several times, every payer is following suit here. It's not about what Medicare is doing. Here's just an example of the 4 random measures, but there are 24 to choose from under OBGYN, so you just got to pick 6 as part of your reporting. And again, that's what a partner would do, come in and set up your EHR to make sure that you're capturing all this information. So a lot of the best practices that I walked through, but certainly there's a publication that just came out. I actually just published a piece here in Becker's Hospital Review. It'll be inside the slide deck that we share with you. Walks through a 4-point plan for MACRA and MIPS success. So walking through financial success, a lot of the revenue streams, setting up your health IT and your EHR to perform for you. This is about leveraging innovation, leveraging technology. I'm sure most of you, if not all of you, have invested in technology in your infrastructure, in your practice, your hospital. You've got to leverage that, and you've got to, or you bring somebody on that will help you set that up. And that's a very key piece. What we do for our customers is set up their EHR to capture their information, to create those essential efficiencies. Technical success, which optimize functionality enhancements. So there's a lot in your EHR, not just about setting up templates, but workflow. There's a lot of functionality that we can make sure that's inside there. One example inside thing is called explosion codes, making sure that you get paid. There's codes that we can pick that can actually bill for 6 to 7 different things. People don't set those up. I mean, there's a great, every specialty has those examples, and there's just so much money being left on the table. But having that technical expertise can afford you a lot of success. And then staffing, again, we covered some of that earlier on, but I dive into it fairly deep in this article. The link is right there for when you get this PDF sent to you. But a lot of opportunities to streamline and reassess productivity, and just to make sure that your teams have the right expertise, or that you augment your team with the right expertise, and educate staff into where healthcare is evolving. It's not about doing the same thing that you've done in the past. You really got to make sure that everybody's keeping pace. Again, cover that in a 4-point plan. I like this slide, and came across this content just last week. It's all nice and concise. But I got a question. Must you have an EHR to submit for MIPS and for the QPP? And well, the answer is no. Technically, you don't have to have an EHR. If you don't submit via an EHR, or certainly for a certified EHR, it's going to be much more difficult, and you're going to be extremely less efficient. And so I'm a big proponent of using an EHR. It doesn't have to be any specific one. Certainly anything in the top 10 or 15 EHRs, or certainly one of the top 5 in your specialty, are all going to be good. And you do want to understand what their MIPS program is. I mean, there's several that have their full MIPS plans, and they've got the MIPS releases coming out, MIPS reporting releases. That's fantastic. But EHRs are just very strong from a lot of the tenants in optimizing your practice. So I left this slide in there. I like this slide because EHRs do lead to quality increases in most settings, at least from what I've seen. But again, as I mentioned, it's not just about what CMS is doing. Here are just there's going to be 6 random examples across different states. But Aetna has a great PCMH program. There's so much money to be had in PCMH, but also I think it's very important to note that PCMH will also help you qualify for your MIPS categories. So in improvement activities, PCMH and medical home get full credit just for running a PCMH. So again, there's a lot of benefits or cross benefits that help you. Georgia has a PCMH university as well, and then the oncology care model, $160 per beneficiary for those OCM services. In Kentucky, and again, these are just random examples. You got the personal health care program where they increase the on top fees paid. The primary care initiative, the CPCI, which actually I was part of a couple of years ago. Additional money there, and then certainly Blue Cross. All Blue Crosses have different types of value-based care programs available in different states. This happens to be one from Florida. But usually there's an additional 5 to 15 to 20% that you can get on your visits and encounters if you're capturing certain information or reporting on certain information. And then you begin to show more outcomes reporting. So as a highlight, what it'll take to succeed financially, you've got to pay close attention to the bottom line. You can't afford to relinquish any money that you've earned. You and the practices and the providers, you're doing the work. Just make sure you get paid for it. And I promise you, when you have the right partner or helping in the revenue cycle side, and even on the clinical financial administrative side, there's an additional 5, 15 to 20% that you can garner. And you've got to optimize your efficiency on the clinical side as well as the financial side, as I mentioned a couple of times, and pay, again, close attention to the nuts and bolts of your revenue cycle and even your clinical side. But look at eligibility verification, authorization management. You want to optimize coding. You want to make sure you get the right claims being created. You're scrubbing them before they go out. Inserting before submission, and managing your denials. And when you have denials, get right into the root cause of that, mitigating that, so you don't so you send out cleaner claims, but then also you submit, or you're chasing that down 100% of the time. You've got to make sure you have a tenacity in chasing down and resubmitting those denials. And pay very close attention to payer contracts and variance rates. Again, 6 to 12 months, looking at those, because I promise you, you're going to find a lot of money there. You're not being paid to the rates that you negotiated. They play the game, and you want to make sure that you play the game back, or you have the right resources on your side to play that game back. And you set up KPIs across the board, KPIs on the finance side, and certainly KPIs on the clinical side. And specifically on the clinical side, you want to look at integrating data from clinical and financial sources. That's going to be very key in value-based reimbursements, looking at total cost of care, looking at your total cost of operation. How do we streamline it? You want to, and I mentioned, set up your EHR and create dashboards to capture and monitor your success. One of the best practices that we do is we go in there every single month and see how you're capturing the MIPS information. And do you need it adjusted? Are you, real basically put a scorecard, red, yellow, green. If you're doing well, you'll be at green, or yellow, you're in risk of not achieving your full incentive, or red, you've got to retrain you in some areas. So those dashboards are critically important, and most good EHRs have those dashboards in there. So again, it's not buying more software, more technology in most cases. It's about deploying what you already have. And again, I've just mentioned it, a monthly scorecard to review. You want to review your KPIs on the financial side and KPIs on your clinical side. A lot of money to be had on both sides. And care coordination is getting much larger. You're gonna see this certainly with MIPS, and then with obviously new payment programs that are coming. You want to look at different ways to optimize how you provide care for your patients and engage your patients. And here I'm closing out: patient engagement, education, and empowerment. Patients they're a free tool for you in many ways. You want to make sure that you're empowering them, you're educating them, and you're engaging them with their health care, offering them the information so they can better manage their health care. It's not all what you can do and what you need to do in the practice or hospital level. We need the patients do want to take better care of themselves, because at the end of the day, they're the beneficiaries of better health. You might get some of the financial incentives, but they live the realistic incentives, the quality of life incentives. So, and if anybody's ever heard me speak before, I personally believe that all care providers that intentionally and deliberately engage new payment and care delivery models and create the right partnerships will have more opportunity in the future than we have today. And I wholeheartedly believe that, because I live and breathe that every single day. And I love to navigate the future of healthcare in partnership with practices and in partnership with hospitals, because it's exciting to be able to see it evolve and see payment increases and more revenue sources to be untapped. So additional resources, we link here to the Quality Payment Program, which will cover all of the MIPS program, will cover all of the advanced APN programs, and both of those MIPS and APNs are under the QPP, which was initiated and put into place by MACRA. I know a lot of acronyms, but that's just how the government in our industry rolls. iHealth, if you ever want to see some of our upcoming webinars and our speaking engagement and be educated, even down to specialty-specific level, you can click on that link, iHealthinnovations.com. And another great site that I like is innovation.cms.gov. That will show you all of the value-based payment programs and models across the country, not just what CMS is doing, but what the private and commercial payers are doing in a lot of cases. And to show all of the opportunity for additional revenue for your bottom line. Because I love not only, I love to partner with practices to certainly walk them through PQRS or meaningful use and now MIPS, but I like to go get additional revenue from quality reporting initiatives. A lot of the time, it's no additional work that the care provider needs to do. It's just sending out a report to somebody and getting $150 or $200 per patient per month in some cases. It's exciting, and it's a lot of opportunity there. So I'm going to turn it over now to some questions. We may run a little bit long. You can certainly drop if you would like, but if you want to listen to some of these great questions I'm sure the audience are going to have, you're more than welcome to stay on. So Alex, I'll turn it back to you.
Thank you, Justin. We're quickly approaching the top of the hour, so I'll go ahead and dive into our first question. I own a small practice and fear I will get hit with a penalty. Can you go back over the minimum requirements to avoid a negative payment adjustment for next year?
Sure. So it's very simple. Each of these are for a 90-day period, but you only have to report on one quality measure or one improvement activity or 5 advancing care information measures. So it's very simple, and anybody that you may partner with or you can read online, you can achieve that very, very simply. And again, any of those one or 5 things, one quality measure or one improvement activity or 5 advancing care information measures over a 90-day period to avoid that 4% negative payment adjustment. So very simple. Great question.
Perfect. Next question. And actually, this is more of a comment than it is a question, but I do think it's important to address. We have an audience member who has expressed that they are not at all interested in participating in a quality payment program and that they would rather face the penalty. Justin, if you could add some color in your thoughts here, I think it would be helpful to most folks on this call.
Sure. I mean, bottom line is if you don't participate, you are gonna you're gonna get a 4% payment adjustment and then 5% and then growing. So I think it's something that I wouldn't. And so these are also cumulative. So I wouldn't exactly not participate. And people can say well, I'm not going to participate in Medicare. It's not just about Medicare. This is about all commercial payers, the Blues plan. They're all moving down this path very quickly. Cigna and Aetna and everybody is flying down this path. And to be honest, a lot of those commercial payers have outflanked even Medicare. They have these programs already out in their communities today. I've been doing this for 4 years now on the ground with practices and hospitals. And Medicaid is in the same boat. And we work with Disrupt and Health Home up in New York and other states across the country with Disrupt, which is Delivery System Reform Incentive Payment. That's an alternative payment model. So these are all over. They're all around us. We just really have to evolve. And again, this is so watered down, in my opinion, that you can be successful. Just get a little bit of maybe advisory help or anything iHealth can do for you, let us know. A great question, Alex. Thank you.
Thanks. We have time for one more question. We are currently on the upgrade waiting list for our EHR. Will my practice be penalized if we don't have the latest MIPS edition?
No, and that kind of goes back to where really picking the right set of measures for your practice. So no, you will not. The bottom line is you will not be penalized. You do want to push your EHR provider for the very best version quickly. You hopefully will get their updated EHR and their upgrades here in December. In January, but in case you don't, no, you will not be penalized if you cannot report via your EHR or I'm sorry, not on your latest version of EHR that includes MIPS. You will not be penalized.
Great. Thank you, Justin, and a special thank you to everyone for taking the time to attend today's webinar. It's all about revenue, MACRA final rule. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we will also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenters, thank you for joining us today and have a great rest of your day.
Thanks, everyone.